Hello. Hello, everyone. I'm Dr. Chen Huan Chen from National Yangning Jiaotong University College of Medicine, Taipei, Taiwan. My co-chair is Professor Koji Hasegawa from Japan. He is currently director of the Division of Translational Research, National Hospital Organization, Kyoto Medical Center. Welcome to the APSC Cloud Forum of Cardiovascular Diseases series. The theme of the Cloud Forum this year is Paradigm Shift for Hypertension Treatment to Reduce Cardiovascular Diseases and Cardiovascular Deaths. Asia Pacific Point of View. Hypertension treatment is shifting the horizon to comprehensive and effective target blood pressure control, so as to much better reduction of adverse cardiovascular complication and cardiovascular deaths. Innovative clinical trials have demonstrated the long-term benefit of strict blood pressure control in middle-aged, old-aged, and very old-age populations, as well as in different baseline blood pressure entry levels for the reduction of adverse unexpected events, including stroke, acute coronary syndrome, heart failure, and total cardiovascular mortality. Not only pharmacological, but also non-pharmacological modalities are crucial in good health. Substitute in general population, fixed combination polypill, statin, ARB, aspirin, and holistic lifestyle modification by digital health monitoring or guidance further enhance effective hypertension treatment to the whole society in preventive purpose. We are very happy today to have 5 experts from the Asia Pacific regions to share with us the latest advancement in hypertension treatment from the viewpoints of the Asia Pacific regions. It's now my pleasure to introduce today's first presenter, Dr. Zhongdao Wang from Taiwan. Dr. Wang is currently Professor of Medicine and clinical Professor of Medicine and National Taiwan University Hospital and National Taiwan University College of Medicine. And he's also Director, Division of Hospital Medicine and Cardiac Function Lab, Cardiovascular Center, Department of Internal Medicine, National Taiwan University Hospital, Taipei, Taiwan. He's going to talk with us the intensive versus standard blood pressure control strategy for hypertension treatment in older age population, from sprint, step to the real world. Let's welcome Professor Wang.
Thank you, Professor Chen, for your very kind introduction. And it's my great honor to be invited. It's my great honor to be invited to the APSC Cloud. I just flash back to my first slide, but well, I have only 20 minutes. So can you hear me clearly?
Yes.
Is that clear? Okay, great. Thank you so much, Professor Chen, Professor Hasegawa, and Professor Lin for organizing this APSC Cloud. Well, I will give the first talk. The title is Intensive versus Standard Blood Pressure Controls for older hypertensive population from spring step to the real world. I think that, of course, it's just a very important question because most of the hypertensive patients are elderly hypertensive patients. Well, it depends on how you define elderly, but in different parts of the world, there are different definitions. Usually it's over 65, but in some parts of the world, it's defined as over 60. So, well, I will have to say maybe more than two out of 3 hypertensive patients or 3 out of 4 are older hypertensive patients. Well, in the following 20 minutes, I will separate it into 3 parts. The first, I will introduce you the current baby targets, well, in Asia Pacific and around the world for the elderly hypertensive. And the second, I will introduce you the new blood pressure classification and targets in Taiwan because we will issue the updated hypertension guideline.
他有做手术是帮人家是通那个血管。
Yeah, maybe other. Okay, and then finally, I will introduce you also another very important point is about home blood pressure because in our chronic management of hypertension, I think the right modality of blood pressure measurement is of utmost importance, and I think home blood pressure is the one we have to use in our daily practice. So according to the observational data, it is very clear in all people all around the world in different ethnicity. I think there's a continuous positive relation between the systolic blood pressure and the cardiovascular events across ethnicity, across age. And actually, the J curve, the so-called J curve, that means there may be some risk associated with lower blood pressure. The J curve, or the turn, the nadir of the curve, is maybe below 160. And here I use the data from the Korean National Health Insurance Service data because they have the blood pressure value, so they can have such an observation. So it's very clear the positive relation is continuous since the level down to 100/60 millimeter mercury. And in different ages, even though the slope is flatter in the older age, but still it's a positive. And you can see because of the absolute number of events happened much higher in elderly hypertensive. Therefore, hypothetically, if you can lower down the blood pressure to a certain, the similar degree, the absolute benefit may be greater in the elder hypertensive patient. So there's no such J curve in our reasonable level, maybe 120, 130. On the other hand, the J curve should be, the turning point should be below 160. So that set the stage for a more aggressive blood pressure strategy. But in designing or recommending the blood pressure target, we still have to rely on randomized clinical trials or intervention trials. In this BPL-TCC published more than 10 years ago to compare the pharmacological blood pressure lowering and the cardiovascular event reduction in different age. And you can see for people younger than 65 or older than 65, actually the slope is similar. The number is here for every millimeter mercury blood pressure, systolic blood pressure reduction, relative risk reduction is about 2% for cardiovascular events. So that's similar between younger and older population. So older population also get great benefits. If you look at the absolute number reduction achieved by blood pressure reduction, the recently published BPL-TDC trial, probably well introduced by our next speaker, also demonstrated. So here is the figure to show you the absolute number of risk prevented. You can see it's much greater in people older than 65, 75, and 85. So there's no threshold. So it's a continuous in relative risk reduction, consistent, and the absolute risk reduction is much greater in older population. So, but we still need a target, even though we knew from the observational study, we cannot set a goal if we don't have any intervention trial to back up to go about maybe around 120, 110, or 100. So SPRINT is the study to look at, is follow the previous study to lower down the target down to systolic 120 versus 140 to see whether a more aggressive approach can reduce cardiovascular events. So as you may know, you all know that been published 6 years ago, and the result is quite evident. The blood pressure reduction down to 120 is associated with 25% lower cardiovascular risk and all-cause mortality. And 30% of the SPRINT population comes from those with age older than 75. So the SPRINT study can use as a support for the similar or a little bit more aggressive blood pressure target compared to the previous recommendation. So, and you can see, you may all know that the curve separated very early and 1 year after the start of this trial. And the blood pressure difference between both groups is about 18, as I show you in the blue color here, 18 millimeter mercury in systolic. If you divided the relative risk reduction about 25% here by the 18, the number is 1.7%. So quite similar to the previous meta-analysis showing you for each millimeter mercury reduction in systolic, the relative risk reduction is approaching 2%. So I want to emphasize you here because later we will compare with the STEP trial. The STEP trial is done in Asia in the low-risk elderly patient. So you can look at the relative risk reduction for each millimeter mercury reduction in systolic. So what is the number in STEP compared with that in SPRINT? So here is the following the publication of the SPRINT. So there are here is the quite representative meta-analysis to compare 4 trials focusing on patients older than 65 years of age. That's the definition of older. And in these 4 trials, 3 are from Asia. So 75% of population are from Asia. And as you can see here, lowering the blood pressure, systolic blood pressure down to 140 is associated with 30%, around 30% relative risk reduction. So that provides the evidence to support the recommendation for older hypertensive patient, the target of systolic maybe lower than 140. But because the SPRING is done in the United States and is sponsored by NIH, so American Heart Association revised their recommendation in 2017. So they recommend the blood pressure target universally below 130, including older population. They did not mention the target for the diastolic because quite a few older hypertensive patients are isolated systolic hypertension. So their diastolic blood pressure is already below 80. So that's the reason why to avoid the confusion. So they provided only the 130 targets. But on the other hand, on the other side of the globe, the Europe, they did not accept this recommendation. Actually, they recommended 130 to 139, below 140, but within above 130. So that's I mean, to me, I think it's a contrast to what being recommended American Heart Association 2017. So in this European guideline published in 2018, they recommended for the elderly people. Still, we can be more aggressive, but the definition of aggressive is lower to set a target below 140 rather than 150. However, they also said the lower threshold, lower range is 130. The reason is mainly comes from post hoc analysis from on-target and transient. Actually, all kinds of post hoc analysis are hypothesis generating. They cannot use to support a hypothesis, just generate a hypothesis, and it can be confounded by the reverse causality. So that's the weak point for the European guideline. So that's the contrast between America and Europe. Another insufficiency in evidence is about low risk older patient. In the HOPE-3 study, it's focusing on low risk patient. You can see here the placebo group, the annual event rate, that's 5 endpoints, but it's only about 1%. Compared to SPRING, that's more than 2%. So SPRING is intermediate people, hypertensive people, and but HOPE-3 is low risk people. In this study, routine use of fixed dose combination, but it's not always associated with lower events. It only being associated with benefits in patient older with systolic pressure greater than 143. So, and the 8-year follow-up data recently published in European Heart Journal, again, reassure the finding in the original HOPE-3. So following 8 years, you can see the benefits only observed in patients with systolic blood pressure greater than 143. So for the low risk older patient, even though the age is the most important determinant of cardiovascular risk, but still there's a huge variation in the overall cardiovascular risk in older patients. So I think there are two controversy issues. The first is the contrast between America and Europe for older hypertensive patient. And then it's the low risk, whether there's enough evidence to support a more aggressive strategy for lower risk older hypertensive patient. So here's the list of all the recommendations. So it's a more aggressive in America, the lower than 130 versus the other, a more conservative approach. So then we move to the second part, the new BB classification, the targets. We basically we agree with the American recommendation in our Taiwan Hypertension Society and Taiwan Society of Cardiology. In the updated, the will-be published Taiwan Hypertension Guideline, we revised our definition of hypertension down to 130/80 because of the continuous risk associated in the observational study, not only in Europe, in Caucasian population, but also in Asia, East Asia, like demonstrated in Korea, and also the SPRING trial and the other and the meta-analysis. So we consider to change the definition lower down to 130/80 and based on whole blood pressure. So that's another different, significant change, the paradigm shift. The home blood pressure based recommendation actually being advocated in Japanese guideline many years ago. So it's not that kind of paradigm shift, but for most of the Asia or around the globe, I think we are the second country to recommend to use home blood pressure from diagnosis to monitoring. And with regard to the blood pressure targets, we recommended two sets of targets, 130/80 and 140/90. For low risk patient initially, I mean, after the publication with STEP, well, we changed a bit. So for low risk patient, 140/90 based on home blood pressure, and for the rest of the higher risk patient, 130/80 for all of them. And especially for higher risk patient with established cardiovascular disease, probably if the patient can tolerate 130/80, below 130/80 quite well, we can, well, more aggressively to reduce the systolic pressure down to below 120. So, and then because we are just preparing the guideline and the STEP published a couple of months ago in the European Society of Cardiology meeting, and the STEP trial wants to answer whether this finding in SPRINT could be replicated in, well, I mean, in Chinese population, in China, Taiwan, and in the lower risk, because the risk in the Eastern population is a bit lower, I mean, compared to the Caucasian population. So STEP wants to replicate whether the SPRINT could be published. Well, I was honored to be invited to join the steering committee of the STEP, and we also provided 200-page cases in the STEP trial. So the STEP trial done in mainland China and Taiwan since 2018. And the STEP trial included 42 clinical sites, and the target, there are two targets. It's above the 130 and below 130. But if you look at the design, there's a range between 130 and 110. And the other group is 130 and 150. So that's, well, quite interesting, because if the blood pressure lower down to below 110, the meaning of the lower threshold means maybe you can adjust the medication, you can down-escalate the number of medications. The inclusion criteria is very simple. People with blood pressure greater than 140 or on any antihypertensive medication, irrespective of any blood pressure level, and age should be within 60 and 80, because the definition of older is 60 in China. And patient with prior stroke being excluded, because there's another study being done, and the diabetes, patient with prior diabetes being included. So that's a difference between STEP and SPRINT. And the blood pressure monitoring is conventional rather than the automatic blood pressure monitoring in SPRINT. So that's one critic, heavily criticized of the SPRINT. But in the STEP, the blood pressure are our traditional way by trained physician or nurse, and measure 3 times with 1 minute apart, and then average it all 3 measurements, rest for 5 minutes, and all made by manual. The only automatic is the inflation of the cuff. And home blood pressure monitoring being recommended at least 1 time a week. The medication used is olmesartan, amlodipine, and azithromycin. And the primary outcome is similar to the SPRINT and the other Framingham study, HOPE-3. It's basically the 5 endpoints include, and in addition, adding atrial fibrillation and coronary revascularization. So that's a bit different, a bit more to want to have more events to be compared with. And there are more than, finally, there are 8,511 patients being, well, randomized into 2 groups. The loss of follow-up rate is extremely low, only 2.7% in the real world population. And as you can see here, even though the patient with age between 60 to 80 be included, but 3 out of 4 are in the stratum between 60 and 70. And 1 in 4 are in the stratum of the 70 and 80. The baseline blood pressure is 146/82. And the diabetes comprised of 20% of the STEP population. So that's a huge difference between STEP and the SPRINT. And as you can see here, the 2 groups, they are 9.2 millimeter mercury difference in systolic blood pressure across throughout the course. And the most commonly used drug are combination CCB and ARB. And then it's CCB, about 10%, CCB alone, about 10% in the intensive group. The differences in number of medication is only 0.4. So that demonstrates the efficacy of this auto antihypertensive drug. With this 9.2 millimeter mercury difference in systolic, 26% difference in primary events being achieved. So as I mentioned to you, if you divided this 26% by 9, you can get a 2.8% number. So it seems that in Asian population, while the clinical benefits are greater than that being achieved by the blood pressure reduction in Caucasian population, 3% versus 2%. And almost all different kind endpoints are different. So stroke, acute coronary syndrome, heart is about 33%, heart failure 73%. So that's typically the most responsive element in elderly hypertensive patient while through the blood pressure modulation. And there's no differences in all-cause mortality because the number is very low. You can see here, the STEP patient is a low-risk elder patient. So the all events, the primary endpoint outcome is only about 1% a year. So if you define the primary endpoint by CV death, non-fatal MI, and non-fatal stroke, that's only about 0.7%. So that fall into the category of low risk. So that fill the gap of the evidence. The low risk patient, lowering the systolic blood pressure below 130 also provide significant clinical benefits. And with regard to the side effects, everybody worry about the side effects, but the only side effects happen more frequently in intensive group is hypotension. But in terms of the dizziness, fracture, syncope, there were no difference between both groups. There were no difference in renal events, but because we did not collect proteinuria. If we collect proteinuria, I may assume the proteinuria may be lower in intensive group, but there's no evidence. Somebody worry about for patient with isolated systolic hypertension will get benefit or not, or get more harm. But in the STEP, as you can see here, for those with diastolic blood pressure below 60 or pulse pressure greater than 60, all got benefits. Similar, there's no heterogeneity. So that's the STEPS trial. And then we move to the source substitution. The only reason, because that being introduced by our following speaker, the only reason is I want to show you the relative risk for each millimeter mercury reduction in Asian population. So SAS is done in China again. And the inclusion criteria is people aged over 60. So that's also an older population or with a prior stroke. As you can see here, with the source substitution, only 3.3 millimeter mercury difference systolic. However, the relative risk reduction in stroke or major cardiovascular events is around 14%. So if you again divided this 14 by 4.3, it again shows you in Asian population, in Chinese population, the relative risk reduction associated with each millimeter mercury reduction is systolic. Actually, again, higher than that being achieved in Caucasian population. So according to all this evidence, we changed our targets. We made a universal 130/80 based on home blood pressure targets for all hypertensive patients from low risk to high risk, from younger patient to older patient. So there's no difference between younger and older. Actually, the definition older is arbitrary. And then we want to mention here, how to safely reduce the blood pressure in the elderly. You have to follow these 4 things, very easy things. First, you have to remind the patient about any symptoms of hypotension or hypoperfusion, like in brain, dizziness, weakness, but in heart, maybe breathlessness or some breathlessness or some chest discomfort. And the kidney, if the urine it's got edema or urine flow decrease. So it's very easy to be judged by the patient themselves. And you can recommend the patient to measure their home blood pressure while standing. So you can see whether there is any evidence of orthostatic hypotension. If there is orthostatic hypotension and symptomatic, you may be more conservative. and adjust the medication based on home blood pressure measurement. So that being mentioned in our guideline and also in our home blood pressure consensus, and adjust the medicine by monthly basis. Don't rush, don't be rushed. So finally, the home blood pressure is very important and being emphasized in our guideline, and I think in the real world. So how to conduct a formal or reliable home blood pressure measurement and also got a reliable number, we recommend this 7-2 principle. It's very easy. So you have to, based on this 7-2 cycle results, to adjust to make your pharmacological medication adjustment. So 7-2 means you measure home blood pressure for 1 week and average the 1 week level, at least 4 days. And in 2 occasions a day, one within after wake up and before sleep within 1 hour. And in each occasion, you measure twice with 1 minute apart. So an average all. So my simple summary here. So we recommended a universal definition of 130/80 based on home blood pressure following 7-2 for all hypertensive patients, including elderly, and a universal target less than 130/80 and based on average the morning and evening in these two. These two levels should be below 130/80 rather than the average of these two. So that if each individual separate targets should be set for morning and evening the same level for 130/80 for the elderly hypertensive patient. So thank you for your attention, and I look for your questions.
Thank you, Professor Wang, for your very informative talk. Now, Professor Wang's talk is open for discussion. Any question from the panelists?
Okay. Can I make a comment?
Yes, please.
Yeah, thank you very much for a comprehensive lecture on the strict blood pressure control in the world. Especially, I'm very interested in the difference between Asians and Caucasians. And you showed that the Asians will have more benefit by strict blood pressure control rather than the Caucasian. And how do you think about the mechanism? Because the Asians have the higher baseline blood pressure level than Caucasians, or Asian will have more stroke rather than Caucasians. How do you think, why do you think the difference between Asians and Caucasians? And could you have a comment, please?
Right, that's a very important question because in observational study like done in the Asian Pacific region and published years ago, we demonstrated, but that's in observational study with the similar, the increase in systolic blood pressure, but the proportional increase in cardiovascular events are higher in the Asian compared to Australian and New Zealand, the Caucasian population, even in the same Asia Pacific region. So that's a very, well, I mean, the typical example, but that's for the observational study. But so I always just, like you mentioned, I always want to look at in the pharmacological intervention study, can we replicate this finding well observed in the epidemiological study? So I raised this issue like in the STEP and in the SARS. We observed this. The reason, well, it's all hypothetical, but I think, basically it replicated observational study. And maybe it's more friable. The Asian people, it's more easy to get cerebral vascular events. You know, in the cerebral vascular event happened maybe around twice, 2 times or 3 times higher the incidence compared to Caucasian. The Caucasian have a higher incidence of myocardial infarction. So I think maybe the cerebral vasculature is more vulnerable to blood pressure change and therefore the reduction. And I think Taiwan and Japan, we all observed the significant drop in the mortality from intracranial hemorrhage, 70%, 80% throughout these years. So I think maybe the structure can explain something. The vascular structure is more vulnerable. I don't know whether there's a more blood pressure fluctuation in Asia or because blood pressure fluctuation could be reduced by pharmacological intervention as well. But that been well because we usually look at the average blood pressure, but that may explain part of the benefits, extra benefits observed in Asian population. But we need more evidence. I think that Professor Cario also does quite a few studies to demonstrate this. Maybe Asian people got more early morning hypertension due to salt sensitivity, and that's maybe another reason. So I think the vasculature characteristic and also the blood pressure profile characteristic. These two characteristics may explain most of the extra benefits obtained by the Asian population.
Yeah, thank you very much for your
Professor
excellent
Wang.
comment.
Because of time constraint, it's my pleasure to introduce our next presenter, Dr. Eddie Madian Ambery from Department of Cardiology and Vascular Medicine, Faculty of Medicine, Universities Indonesia, and National Cardiovascular Center. And the title of his talk is Age Stratified and Blood Pressure Stratified Efficacy of Hypertension Pharmacotherapy in Prevention of Cardiovascular Disease and Cardiovascular Deaths, Asia Pacific Point of View. Welcome, Eddie.
Thank you very much, Professor Cheng, for the introductions. I'll share my slide first. Okay, that's clear.
Yes.
Okay, thank you very much, Professor Chen, for the introduction, and then thank you very much for the APHG who invited me as a speaker in the APHG class this day. I think before this, I think that I really enjoy Professor Wang talk about the hypertension, especially in Asia. But this is my turn. I will talk about the age stratified and blood pressure stratified effect of blood pressure lowering pharmacotherapy for the prevention of cardiovascular disease and death. Asia Pacific point of view. Okay. Yeah, as well as you know that hypertension is the major cause of mortality and leading cause of cardiovascular disease worldwide. And then blood pressure lowering either by lifestyle modification or medication lead to the reduction in cardiovascular events. In our center, in National Cardiovascular Harapan Kita, there is a changes in the risk factor, especially in acute coronary syndrome, about 2016. Mostly of them is the first risk factor is a smoker, but now hypertension is become the first risk factor of acute coronary syndrome here in our centers. And then increased blood pressure, of course, it is a major risk for cardiovascular event across different age categories and offer a wide range of blood pressures. There is a controversy, of course, that Professor Wong stated before. In older patients still, the question is that the older patients still gain benefit from blood pressure lowering agents? Because there is a different guideline from US, from ACC, for example, and ACC about this. And then because what? Because the cardiovascular event rates increase with age. And then the other thing that all the patients with lower blood pressure had increased risk of cardiovascular event compared to those with higher blood pressure. And then there is a conflicting guideline, especially a clinical guideline recommendation for treatment according to age. This is the prevention of hypertension that I get from the Lancet 2020. If you see here is that worldwide, there is almost, in women, they found that 59% diagnosed with hypertension, but just only 47% treated and only 23% control. How about in South Asia? Almost the same. You see here is that hypertension diagnosed in 45% populations, and then only 37% treated and 70% with controlled blood pressure. This is in women. And then in men, of course, is smaller than women. You see here that the diagnosis of hypertension is about 49%, and then the treated about 38%, and the controls only 18%. And then in South Asia, it's smaller, about 33% diagnosed with hypertension, and 26% is treated, and only 11% with a controlled blood pressure. I think there's a big problem in now, not only in Asia Pacific in our regions, but in worldwide. And then in Indonesia, this is my colleagues from National Cardiovascular Center Harapan Kita, Wiantoro Bambang. There is a Indonesian May Measurement Month, which is published in European Heart Journal. And then they make a total 69,000 individuals screened at that time, and then found that 35.5% had hypertension. Of individuals not receive antihypertensive medication, 20% were hypertensive, among individuals receiving antihypertensive medication, 62% had uncontrolled patients. It means that even though the patient got a medication that we give to the patients, the blood pressure are uncontrolled. That's a big problem. And then this is the global measurement mark from the European Heart Journal 2019 that we see here in South Asia, East Asia, Southeast Asia, and Australasia. The proportion of hypertensive control is only around 25 to 40%. And then if we try to looking for the income strata, of course, that this is comparison across country income strata, so that lower proportion on treatment and lower control rate among the treated in low income countries relative to other income levels. So of course, that we have a problems in Indonesia, even though we have a universal coverage for the insurance for all of Indonesian people, seems that really difficult to give good medical treatment for the patient with hypertension. As Prof. Wang stated before, in Taiwan, they put a cutoff of 120 in systolic and 80 in diastolic, but I think that's in Indonesia, as a low middle income country, we just still use of 140 of ET for the cutoff of treated patients with the hypertension. Actually, that the absolute cardiovascular event rate increase with ages. Maybe this is one of the pathophysiology in aging. Of course, that this increase in metabolic syndrome, and then increase in inflammation, and then neurohormonal disorders, and then it's made endothelial dysfunction, arterial stiffness, and hypertension. And then this is maybe a factor why in aging that we still think that it is always increase in blood pressure than in young people. But actually, that robust evidence from randomized controlled trial has been lacking, part because of the underrepresentation of all the individual in clinical trial. If you see here, this is from Professor Cario. This is a factor contributing to hypertension and cardiovascular disease in Asia, because you know that in Asian people like a salty food, and then mostly they are obesity, have a diabetes, metabolic syndrome, and then a lot of pollution here. And then about the urbanization, of course, this is the factor that contributing in hypertension in Asia. This is one of, I think that's one of the big RCT. This is the only large-scale trial that has exclusively recruited patients aged 80 years and older, with more than 80 years. There is almost 4,000 participants from Europe, China, Australasia, and Tunisia. Were selected on the basis having very high blood pressures. It's mean that in this trial, they put 160 millimeter mercury to give a treatment in patients with over 80 years old. It means that they give indapamide, and then perindopril. The systolic blood pressure is decreased, and diastolic blood pressure is decreased. But in this study, you see, this study found that 30% reduction in risk of stroke and 23% reduction in risk of cardiovascular death, which you see. And then there is one paper that Professor Wang stated before. It's from the Lancet 2021 about age stratified and blood pressure stratified effect on blood pressure lowering pharmacotherapy for the prevention of cardiovascular disease and death. This is a meta-analysis from 52 clinical trials, almost 350 randomized assigned patients, and then there is all the populations, about 22,000 patients, more than 80 years old, with the inclusion criteria, pharmacological blood pressure lowering treatment with at least 1,000% a year of follow-up, and the RCT that provide outcome and age and blood pressure baseline. Then exclusion criteria is previous history of heart failures, and then the outcome, the study outcome, the primary outcome is fatal or non-fatal stroke, fatal or non-fatal myocardial infarct and ischemic heart disease, heart failure causing death and requiring hospitalization admission. Secondary endpoint is all-cause death. It's component primary outcome. And then they try to make age and blood pressure stratification, for example, like this, less than 55 years old, and then until more than 85 years old, and the blood pressure they try to stabilize into the less than 120, 120 and 20, 129, and then until more than 170, and then diastolic blood pressure too. This RCT include RCT from Asia, including KSG trial, COM trial, COP trial, HG trial, home blood pressure trial, etc. And then mostly the RCT from Asia is come from Japan. I think that Japan is very active in this. There is a trial which is that I think that this meta-analysis that can use as one of the resource for our maybe making a guideline. And then the cumulative incidence of the primary outcome stratified by age categories at baseline and the treatment allocation show an increased incidence by increasing age. You see here is that when the age increased, it's better it increased incidence of the primary outcome. And then in all age group, even rates were lower in the interventional than in comparator group. The confidence limit was reached in the group of individual age 55 years or older at baseline, and reflecting the smaller number of participants even in this group. It means that if you see here, mostly the patients age more than 85 years old is small, but the absolute number of reduction in cardiovascular or the primary and secondary outcome is very big. This is the forest plot, age stratified relative and absolute risk reduction for the primary and secondary outcome. A greater relative risk reduction in youngest age group, of course, and then smaller effect with the what confidence interval in those age 85 or older at baseline. Higher event rate in the older group. If you see here that in older group, the high event rate, even though it's small, but the event rate is high. And a higher absolute reduction in the risk of major cardiovascular event in the older group. You see here, the absolute reduction actually in the older group is higher than in the younger group, I mean less than 55 years old. And then in this study, actually, there is shown no evidence of any heterogeneous treatment effect by categories of systolic blood pressure at baseline on the risk of major cardiovascular event in any of age group. No clear pattern of increasing proportional effect among individuals with a higher baseline systolic blood pressure on the risk of major cardiovascular event. The effect of diastolic blood pressure reduction stratified by baseline diastolic blood pressure categories and age groups on the risk of major cardiovascular event show no heterogeneity of the treatment by diastolic blood pressure at baseline. And then from this individual level meta-analysis show that pharmacological blood pressure reduction is effective across the wide range of age with no evidence to suggest that the relative risk reduction for prevention of major cardiovascular event vary by baseline systolic or diastolic blood pressure level. And this is the very guideline that we have from the ACC and American Heart Association, the 2017 American College of Cardiology and American Heart Association guideline are an exception in not making an age distinction for the treatment recommendation. It's mean that in America, there is no distinction for the treatment recommendation. That's very different if we compare it with the AHC guidelines in 2018. The European Society of Cardiology and European Society of Hypertension set the threshold for consideration of drug treatment in those age 60 to 79 years at 140 over 90 millimeter mercury or greater, and in those age 80 years or older at 160 over 90 millimeter mercury or greater. And then from the NICE guideline, we know that in 2019, National Institute of Health and Care Excellence guideline for England Do not recommend treatment in adult older than 80 years if the blood pressure is lower than 150 and over 90 millimeter mercury. I think this is almost the same with Professor Wong talk about the sprint trial, SPED trial, and SAS trial, that maybe we should change the guideline and then give a rational cutoff for the reduction in cardiovascular disease in the future. And this is from Indonesian. This is from Indonesian Society of Hypertension that we are consider giving still consider that giving a monotherapy for the patient more than 80 years old, and then in elderly patient with hypertension, we give CCB as first line, and then after that, sometime that we give a thiazide to the patient. And then as a conclusion, there is no evidence to substantiate the common approach of withholding antihypertensive treatment for older adults, in particular when their blood pressure is not highly elevated. Overall pattern were consistent and suggestive of worthwhile reduction in cardiovascular outcome across all age group. And then pharmacological blood pressure reduction should be considered as an important treatment option for the prevention of cardiovascular, even in those age 80 years old or older. And then guidelines should be simplified to remove any differing blood pressure threshold by age. I think this is, thank you very much, Mr. Chairman.
Thank you, Eddie, for your very informative talk. Now, any comments from the panelists?
Okay. Yes, just I'd like to make a comment, but the specific, maybe the specific question to Indonesia, that you said the low-income people or poorly control the hypertension. Why the low-income person are poorly controlled? Because they do not visit the hospital, or they do not take medicine, or they are not educated, because the government will cover the expense of the medicine. Why the low-income persons are poor controlled? Do you have any speculation?
Yeah, thank you very much, Professor Hasegawa. I think it's Indonesia is really different with Taiwan, for example. And then we should be careful to give a target, especially in cut-off of giving a medication for hypertension. For example, that we use American College of Cardiology, and then cut-off is more than 120 or over 80. Of course, there is a lot of money that you should give to, I mean, the government should pay a lot for the treatment, even though it is give a lot of impact in the prevention of cardiovascular disease. A lot of factors that can be happen for us. For example, that Indonesia, maybe in my country, one of the sample, we are very large archipelago. Of course, that we have a universal coverage in Indonesia. We have a BPJS that's very good, but actually that they should come to the primary care, or they should come to the hospital to get a medication every month. That's the problems. They should come every month, and then the hospital will give you medication. And then the medication is not the same between the primary prevention, I mean primary care, and then the hospital, because not all kind of medicine, you can get in the, for example, that in the primary care. In the primary care, you just have maybe ACE inhibitors, no ARB, just only have a thiazide, then CCB, maybe amlodipine, just only that. But I think that's due to that, to control the blood pressure is a little bit difficult, because beside the compliance, and then we have problems with, that lifestyle too in our country, mostly of them by sedentary, and then eat a lot of salty food, maybe most of us, yeah, and then it's one of the big problems beside the treatment of hypertension.
Thank you very much.
Yeah. Eddie, since the relative benefit of blood pressure reduction is the same across different age groups, do you think we still need the age stratified BP targets for hypertension control?
Yeah, I think that I'm agree with Professor Wang. Yeah, I think that giving a medication for the people, I mean all the peoples. Yeah, you don't need to wait till more than 160, for example, like that. Maybe for me myself in Indonesia, if the patient come to you with a blood pressure more than 140 over 90, you should try to give a treatment. Yeah, beside the lifestyle modification, I think that we should think again about that, Professor Chen. Thank you very much.
And Professor Wang, in 2022 Taiwan hypertension guideline, do we still have a age-stratified blood pressure target?
Well,
For
we
the elderly?
don't have, yeah, we have we recommend a universal targets, but I think we have to mention for older patient because there's still controversy. So
Yeah.
just let them realize the evidence to support such a universal recommendation. So theoretically, we don't have to mention age specifically, but because there's a connection between the older version and the new version. So we just let them to realize why we made such a universal recommendation. So that's the only reason why we mentioned age-specific target again. Otherwise, there's no need to mention that. Right?
Okay.
Thank you so much.
Any comment from other panelists?
Yeah, Adni Menes here.
Yeah.
Dr. Wang and Professor Wang and Professor Ambari. How low is low? How low can you get, or is it safe for elderly and other age range patients?
Okay.
Yes.
Actually, yeah.
No J curve is already.
Yeah, actually, that me myself, and as a clinician, I think that for the older patients, more than 70 years old, I think that the cutoff of 140 over 90 is the cutoff for us. It's mean that I don't know, but in the meta-analysis, I mean the lower blood pressure is have a risk reduction in cardiovascular disease in the future. So.
Right.
Maybe Professor Wang, you have additional.
Right. Thank you, Adi. My answer is that should be individualized, but to be specifically, well, depends on the symptom of the patient. If the patient don't feel any hypotension symptoms, syncope, or fracture or fall, well, basically the level should be acceptable. And then more broadly, I think about the range, the meaning of range. That maybe means the lower part. We may start that the lower range can be set as a threshold for starting to lower down your strength of antihypertensive medication or to cut the number of medication. And the number here for the lower the threshold to stop to reducing medication may be around 110 millimeter mercury systolic, just like we said in the STEP trial. So I think previously I may consider 120, but recent years, my personal practice is about 110. If the patient totally asymptomatic and maybe at higher risk, I will be more aggressive. So just as the symptom of the patient and the number may be 110 based on the STEP.
Thank you, Professor Wang. Now it's my pleasure to introduce our next speaker, Dr. Rodney Jimenez from Philippines. He is currently Assistant Professor, College of Medicine, University of the East Raymond Magsaysay Memorial Medical Center, and Head, Resuscitation Service, St. Luke's Medical Center, Manila, Philippines. The title of his talk is Salt Reduction or Salt Substitute for Hypertension Control in General Population from SARS to the Real World. Welcome, Ronnie.
Thank you, Professor Chen. Let me share my screen. Okay. Are you seeing on the screen?
Yes.
Wait. Okay. Thank you again for the kind introduction, Chairman Professor Chen and Professor Hasegawa and Professor Lin. On behalf of the Philippine Heart Association, thank you for inviting us to participate in the APS Cloud Forum of Cardiovascular Disease Series. Likewise, I enjoyed Professor Wang and Professor Ambari's talk. Now, salt substitutes with reduced sodium levels and increased potassium levels have been shown to lower blood pressure, but before this SAS trial, their effects on cardiovascular and safety outcomes are uncertain. I will talk about the salt reduction or salt substitution for hypertension in general population from SAS to real world. So I have nothing to disclose, and the outline is, this is the outline of my talk. I'll talk on the sodium intake in the population, effect of sodium blood pressure and cardiovascular disease, the SAS trial and the recommendations, and the real world scenario. So from the literature I've searched, humans have the capacity to survive extremes of sodium intake from less than 200 milligrams or 10 millimoles per day of sodium in the particular Yanomami Indians of Brazil to more than 10,300 milligrams or 450 millimole per day in northern Japan. And we Southeast Asians also, people are not exempted in the seduction of the salty flavoring. We have our own share of staple salty food sauces like the patis, otak-otak, sambal balachan, and namtong. With regard to consumption by sex, the average intake is approximately 4.2 grams per day in men and approximately 3 grams per day in women. And in another study, they say that men consume 10% more salt than women. And perhaps the greater consumption of sodium in men compared with women results largely from the fact that sodium intake is highly correlated with total food intake, and men consume substantially more than women, especially in young and middle-aged years. As you can see here in this graph, that the biggest source of salt in our diet nowadays comes from the processed food, and only small percentage comes from food, food found naturally in food. No? Now, with regard to world consumption, intakes were highest in East Asia, Central Asia, and Eastern Europe, with a mean consumption of more than 4.2 grams per day. And in Central Asia, Europe, and Middle East or North Africa, the average is about 3.9 to 4.2 grams per day. And regional mean intakes in North America, Western Europe, and Australia range from 3.4 to 3 grams per day. Here is another picture showing that intakes were highest in East Asia and Central Asia and Eastern Europe. Now let's talk about the effect of sodium in the blood pressure and cardiovascular disease. Over 100 trials have examined the relationship between sodium intake and blood pressure. And the best available evidence strongly indicates a direct relation between sodium intake and elevated blood pressure. On average, as sodium intake is reduced, BP is also reduced. And one of those trials is the DASH sodium trial in 2001. As you can see here in the graph, there is direct relationship in the amount of salt intake and the blood pressure level. So it's higher in the control diet and lower in those who were into the DASH diet. So as you consume less salt, the lower blood pressure. And with regard to death distribution attributed to salt consumption of more than 2 grams per day in 2010, according to Nation, deaths related to salt consumption were highest in Georgia and lowest in Kenya. In another study, the association of intake of sodium and blood pressure was more pronounced in hypertensive people, elderly, and those who are taking more than 6 grams of sodium per day, and modest risk in those people taking 3 to 5 grams of sodium per day, and no significant association in the blood pressure in those taking less than 3 grams of sodium per day. Another study revealed that there's an increased risk of mortality and cardiovascular events in people who are taking more than 6 grams of sodium, and interestingly, a lower than less than 3 grams per day of sodium was associated also with mortality and cardiovascular events. And a moderate intake of sodium was associated with lowest risk. Just last year, in one systematic review of randomized trials, they reviewed the effect of dose and duration of reduction in dietary sodium and blood pressure levels. So they reviewed 133 trials with overall 12,197 participants aged more than 18 years old. And they tried to see the effect on BP of the group with reduced salt intake and those with higher salt intake. And what did they find out? This meta-analysis or systematic review shows that sodium reduction leads to a significant reduction in the systolic blood pressure in adults, both female and male, and all ethnic groups. And in both hypertensive and normotensive populations. So the effects of sodium reduction were more evident also at higher starting blood pressure compared to the lower starting blood pressure. So in trials of more than 2 weeks duration, the dose response relation between sodium reduction and blood pressure fall was greater than in trials of shorter duration. But there was limited evidence that interventions of longer duration further increased the effects of sodium reduction on blood pressure. Perhaps longer-term trials that achieve sustained sodium reduction and make multiple assessments of BP are required to properly assess this issue. So now let's go to the China salt substitute and stroke study. So in this study, they reviewed literature emphasizing the high dietary sodium and low dietary potassium is associated with increased blood pressure and the risk of cardiovascular disease and premature death. Some salt substitutes that replace some of the sodium with potassium may lower blood pressure. However, it is not known, it's not clear if these salt substitutes can improve cardiovascular outcomes. This unblinded cluster randomized trial took place in 600 villages in rural China, included about 20,000 adults with a history of stroke or 60 years old or older and had poorly controlled blood pressure. Subjects were then assigned to intervention group that would receive salt substitute containing 75% sodium chloride and 25% potassium chloride. And the other half was assigned to the control group that would receive regular salt containing 100% sodium chloride. So all participants were advised to use the salt substitute or regular salt in all cooking or food preservation. And the primary outcome was stroke. The mean follow-up was 4.7%, and the group receiving salt substitute had significantly lower event than the regular salt group. As Professor Wang said, it has 14% risk reduction. And secondary outcome induced major cardiovascular events and all-cause mortality. Again, for these outcomes, the substitute group fared better than the regular group, and 13% risk reduction in major cardiovascular events. With regard to safety outcome or the clinical hyperkalemia, they did not differ between the two groups. In conclusion of this study, among persons who had a history of stroke or 60 years of age or older had a high blood pressure, the rates of stroke, major cardiovascular events, and death from any cause were lower with the salt substitute than with regular salt. Now let's go to what are the recommendations in the real world scenarios. So here are some of the recommendations I've searched from different organizations. The World Health Organization would recommend 2 grams per day of salt. The American Heart Association, 1.5 to 2.3 grams per day. The Europeans, also less than 2 grams. Our society, we like the American guidelines, so we also recommended 1.5 to 2.3 grams. And the kidney disease improving global outcomes guidelines, also 2 grams. Likewise, the Canadian Cardiovascular Harmonized National Guidelines Endeavor. So, and here are the key broad strategies for salt reduction of the World Health Organization. It includes government policies, including appropriate fiscal policies and regulation to ensure food manufacturers and retailers to produce healthier food or make healthy products available and affordable. And also, they would want to work with the private sector to improve the availability and accessibility of low salt products. And consumer awareness and empowerment of population through social marketing and mobilization to raise awareness of the need to reduce salt intake consumption. And also monitoring of population salt intake, sources of salt in the diet, and consumer knowledge, attitudes, and behaviors relating to salt to inform policy decisions. The WHO has also established global benchmark for sodium levels in food across different food categories as part of the effort in reducing sodium intakes in population. So the setting of this global sodium benchmark is a very important step to facilitate reformulation of food products, which contributes to drive progress in sodium reduction. These global benchmarks are intended to be complementary to ongoing different national and different regional efforts to set sodium targets, perhaps. So, what interventions were effective? In a systematic review I found of dietary salt reduction policies, they reviewed the evidence on the effectiveness of possible salt reduction interventions. And among the interventions that showed significant reduction in the average sodium consumptions are mandatory reformulation or enforced salt substitution, which reduced approximately 1.45 grams per day of the population. And this was seen in 3 separate studies, followed by voluntary reformulation, which reduced salt consumption by 0.8 grams per day, school intervention by 0.7 grams per day, short-term dietary advice by 0.6 grams per day, and nutritional labeling by 0.4 grams per day, but each with a wide range. And tax, community-based counseling, and health education media campaign all reduced salt consumption by 0.1 to 0.3 grams per day. Now, is salt substitute available all over the world? So in other systematic literature review, it was found out that a total of 87 low sodium salts were available in only 47 out of 195 countries. So including 28 high-income countries that comprise 15% and 13 upper middle income countries that compose about 7%, and 6 lower middle income countries that is composed of about 0.04%. And this is the distribution of the availability of low sodium salt in different countries. Now, the average price of low sodium salts was 1.7 times the regular salts. Although in the SAS group, authors said that because it is primarily persons in low income and disadvantaged populations who add large quantities of salt to their diet during food preparation and cooking, and probably salt substitution, a practical, low-cost intervention, may have the potential to reduce health inequities related to cardiovascular disease. And they will also be coming up with the economic evaluation of the China salt substitute and stroke study. So perhaps very soon. Okay, so in summary, a high dietary intake of sodium is associated with elevated blood pressure and the development of hypertension. And dietary sodium reduction can lower blood pressure in both hypertensive and normotensive individuals. They also prevent hypertension and enhance the blood pressure response to most antihypertensive therapies. And dietary sodium reduction should decrease the risk of cardiovascular disease through its efforts on BP and other effects that are probably independent of the blood pressure. And the government working with private sector should be done to improve the availability and accessibility of low salt products, and recommend mandatory or voluntary reformulation and school intervention, among others. So I think that would be my last slide. Thank you very much for listening.
Thank you, Ronnie. Excellent talk. Any comments from the panelists? Ronnie,
Yes.
the
Professor.
salt reduction, is it equivalent to the salt substitute? Are they the same?
I think that would be also the same, but I think it would be personal wise or from the real world perspective. I think it would be easier to substitute the salt rather than reduce the salt by just not adding any salt because of the taste, perhaps because of the seduction of the, the salty flavor, most especially in Asian countries like us. So we like salty food. So probably in real world, it would be better to substitute the salt rather than just reduce the salt. But of course, the World Health Organization would still want they recommend a reduction of salt in our diet. That's why probably this was done also, because it's in real world it's difficult to reduce the salt intake or the salt, just reducing the salt in our diet.
Okay.
Thank you.
Yeah, just a small comment. Could you let me know the taste of the potassium chloride is the same with the...
I have tasted one. It's almost the same. No? It's almost the same.
It's almost the same.
Have you tasted one? Has any one of you tasted salt substitute?
So the low salt is more expensive than
Yes,
salt, right?
yes. It's about average of 1.7 times the price of the regular salt. And some countries, even the high-income countries, have more expensive salt substitute than the other low-income countries, and it's not available everywhere.
Okay. You, if you just told us that there's a J curve between the cardiovascular risk and salt intake. So when sodium intake is less than 3 grams per day, there's an increase in risk. But WHO recommendation is less than 2 grams per day. So there's a controversy, right?
Yeah, I know it's just one trial though, no. So, but there's I haven't seen the other trials that would have seen that less than 3 grams of sodium intake would actually increase mortality also. So I think would take those words with a pinch of salt, with a grain of salt.
Eddie, do you have a comment?
Yeah, thank you very much, Professor Chen. I think that's very interesting, especially if you, you find the patients here come to you with the hypertension, and then you give all of medications, a lot of medications combination, but the blood pressure is too high. And then the problem is that, you know, in Indonesia, we have a salty fish. This is a fish and salty, and then they eat a lot of it. And then the outcome is that we cannot control the blood pressure. I'm agree with you. Maybe we can substitute with others kind of salt for that. Thank you, Dr. Professor.
Okay, thank you, Dr. Rodney. We do Japanese need the more strict control. Thank you very much. So
I know northern Japanese people have a higher.
Okay. Thank you very much. So then I will happy to introduce the Japanese speaker, Dr. Kazuomi Kariyo from Japan. He's a professor and chairman, Division of Cardiovascular Medicine, Department of Medicine, Jichi Medical University School of Medicine, Tochigi, Japan. And his title will be the Digital Therapeutics via Smartphone in Hypertension Treatment from Home Blood Pressure to Holistic Lifestyle Modification. Dr. Kariyo, please.
Thank you, Professor Hasegawa, and also Chen for this precious opportunity. So I'm very pleased to have my talk on the digital hypertension and the management for the to the perfect 20 whole blood pressure control. So let me start my slide. Could you see?
Yes, okay.
Okay, thank you. So for the previous speaker said, the impact of the lowering blood pressure should be the more important for the Asian countries. For this slide show the increase of the systolic blood pressure, office blood pressure, and the association with the risk of stroke and coronary artery disease. Compared to the Caucasians, increase of the systolic blood pressure, the risk is increased in Asia. And also not only stroke, but also coronary artery disease. So we need to keep the lower blood pressure to reduce the coronary artery disease and also stroke. However, the blood pressure control rate is poor in Asia. As shown here, compared to the Western countries, Korea and also the Taiwan is very good, and also Singapore. But the China, India, and also Japan is intermediate. So we have the heterogeneous blood pressure control rate. So we ought to reduce the poor blood pressure control. So in Japan, we stress the importance of the home blood pressure guided approach for the individualized antihypertensive treatment. The keyword is the 3 phases: earlier, more strict, and the 20 whole blood pressure control perfectly. So this shows a prospective study. As shown here, even office blood pressure is well controlled, less than 140 and 90. when home BP above the 135 and the 85, it's a masked hypertension. So its risk almost comparable to the sustained hypertension during the longer follow-up time period. As shown here, the stroke risk and the follow-up durations. Both these two exhibited a benign, as shown here, well controlled and the white coat hypertensive patient. These two groups exhibit the good prognosis. However, the orange line shows the sustained hypertension, but the masked hypertension also catched up the risk to the comparable to the sustained hypertension. So we should consider the risk of masked hypertension comparably to the sustained hypertensive patient. This shows the change in the distribution of the blood pressure control in the J-HOP study. I showed the prognostic study, prognostic outcome. As shown here, when we use the 140 office and 135 for morning, the cutoff values, the poor control rate was the 36 and the masked hypertension was 19%. Well control was 31 and white coat was 15. And when we use the universal blood pressure control of the 130 for both office and the home, the control rate, the masked hypertension was decreased almost the half. However, the poor control group increased from 136 to 58, and the well control for both decreased from the 131 to 14. White coat did not so much change. So when we use the universal blood pressure threshold of 135, so masked hypertension half could be unmasked. So we can target the masked hypertension. So this is our guideline. 2 years ago, we released. As shown here, office blood pressure, the home blood pressure. The uniqueness of our guideline is we documented the target home blood pressure, usually less than 138 for office. But the late elderly patient above 75, we allow to 10 millimeters of mercury higher, as shown here. So, but if tolerable, we think this from here to here is better. And especially for the late elderly hypertensive patient with other comorbidities such as the diabetes, coronary artery disease, or CKD, with the proteinuria, or those with taking the anti-thrombotic agent, we still ask the patient to be more strict blood pressure control, less than 130 and the 80, even they above the 75 years old. And also here, we minus 5 millimeters of mercury from the office blood pressure. So target home BP is the less than 125 and the 75 or less than 75. And the late elderly patient, the less than 135 and 85. So we think the lower the better. And this show the home blood pressure, how important the home blood pressure in the morning. As shown here, compared to the office, morning home blood pressure, the more sensitively detect the risk of both coronary artery disease, as shown here, and stroke, as shown here. But office blood pressure underestimate the risk of the coronary artery disease. But the stroke, the comparably detect. But to detect both the atherosclerotic risk of the atherosclerotic cardiovascular events, then we recommend morning home blood pressure. So I'd like to refer to the second topic on the digital hypertension to reduce blood pressure, especially target should be the morning home blood pressure. This is the first application of the smartphone. They have digital hypertension first program. So for using this, we conducted the DH1 trials. So this application introduced the 6 components of the non-pharmacological interventions into the each individual. The salt intake, the body weight control, exercise, alcohol restriction, and stress management and sleep the improvement. So we test the hypothesis, such a digital approach could reduce the blood pressure. So this was the protocol. As shown here, the primary endpoint was a change of the ABPM 24 hours average at the 12 weeks. So the target population was the unmedicated hypertensive patient. During we randomized into the control group only the standardized lifestyle modification by doctors by only 1 month time period. Baseline, 4 weeks, 6 weeks, and the 12 weeks. So the dot approach by the doctors. And monitor, they ask a patient to monitor their home blood pressure using the same device. Digital approach group, we prescribed the application to monitor and then interactively asked the education and the experience and the evaluation. So each individual approach was introduced into the clinical practice and each patient using the smartphone. So every day, the interaction had been persisted throughout 12 weeks. So not to the dot, the linear line approach. The primary endpoint was the ABPM before and after. And also we correct the home BP changes. After 12 weeks, we allowed the doctors to add the drugs. So this is the patient characteristic, almost 50, and the BMI the 25 around, and the diabetic patient is less than 10. And the no cardiovascular events. And the 24 BP level was around 145. And morning home was around the 150 around here. Evening the 140 around. Office 150. So for intention to treat analysis, the control group was the almost 191, and the digital group almost the 199. And this is the main finding. As shown here, the orange show the digital group, digital approach group, and the blue show the control group. As shown here, digital therapeutic group decreased by 4.9, and the control group decreased the 2.5. So this difference was the 2.4. This was the primary endpoint. We can successfully achieve the primary endpoint, the difference, but it may be too small. But please see here. So morning home blood pressure was decreased by 10 for digital therapeutic group, and the 6.2 reduction was found for control group. So this difference was the 4.3. The office BP was the more extendedly reduced for both. So for this difference was 4.3. So I think this is clinically meaningful. So only the higher BP, 24 BP level was the more extendedly reduced. Other group, no interactions. So this shows also the important figures. So this was a reduction by digital therapeutic group. This reduction. And also here, the control group. Control group also gradually reduced, but its reduction was greater for digital management group here. And even after drug started, this difference remained significant. As shown here, this is the medication status at the 24 weeks. Digital hypertension group, initiation of the medication was the 40.8%, but control group it required the 49.7. So digital therapeutic group could be achieve blood pressure reduction by less medication. I did show the body weight change as shown here. Body weight change was the significantly for digital therapeutic group. And also self-reported the salt intake was greater in the digital therapeutic group. So both body weight reduction and salt intake score reduction, both were correlated with the reduction of the 24 blood pressure reduction by the digital therapeutic group, and the also associated correlated with the reduction of the morning home blood pressure in the digital hypertension group, a digital therapeutic group. So this shows the progress of the application of supported lifestyle modification. So during the study, throughout study, the application engagement rate was almost perfect. And also home blood pressure control rate was also good. Perfect. So this shows the step one, the education stage. After the 12, after 4 weeks, as shown here, step one, especially input of the education. And this is under the orange show the reduction of the salt intake. Step two, it's a experience rate, experience stage. So according to the gradually achieve the application during the study period. So let's consider these values. As shown here, this shows the meta-analysis of the systematic review of the self-monitoring of blood pressure. So self-monitoring per se without the feedback decreased 1 millimeters of mercury. But the self-monitoring with the wave feedback, standard feedback to knowledge, decreased almost at 2 millimeters of mercury reduction. So this shows the feedback and education. Phone or web decreased 4.4. And the self-monitoring with consultation or telecounseling to the individual patient decreased the 6.1. So blood pressure monitoring and also feedback of the individual data per se decrease the almost 6 millimeters of mercury. So this reduction is the also almost the 6. So but this from here to here, this reduction is the benefit of the digital therapeutics, I think. So when we consider this 4.3 reduction, based on the step study, the home morning blood pressure was monitored, and it reduced the change was 7.5 millimeters of mercury. So considered from the step, the result of the morning home systolic blood pressure reduction, we estimate the have DH1 the clinical implication as shown here. This 4.3 reduction had the almost the 20% reduction of atherosclerotic cardiovascular events, and also almost the half the heart failure reduction. So it's a clinical implication estimated by the step. So all this shows the Asian characteristic. Thank you very much for your attention.
Thank you very much.
We need
Okay, thank you very much for your lecture. Very interesting. Do you have? Is there any comment from the speakers and panelists? Yes, in your protocol or after the digital therapeutics, there was a protocol of anti-hypertensive drugs. And could you reduce the amount of the drug by using digital health before the start of the pharmacotherapy?
So we could not demonstrate the statistical significance of the amount. We calculated the therapeutic intensity score for both groups. There are no difference, and also the number of the drugs, as shown here. There are 10% reduction for the digital therapeutic groups compared to the control group. But this difference was not statistically significant. but we need more longer time follow-up period.
Okay, thank you very much. And you showed that the body weight reduced and the salt intake also reduced by digital health. It's very a great impact and very surprised to see that data. But sometimes salt intake, we have too much salt, but sometimes salt intake have some kind of dependency, like alcohol or tobacco. So how could you improve the salt intakes or body weight by digital health? Do you have any comment on that?
Yes. So yes, it's important. The also no pharmacological the improvement is the combined effect. So reducing the salt also should reduce the alcohol intake. So it's a combination effect. But we found the change of the score was with the body weight and the salt intake score was the only two was the associated with the degree of the reduction of the 24 blood pressure and the morning home blood pressure. But we need the exercise and also alcohol or some the information should be more extensively correct in the future study.
Thank you very much, because stress management is also important
yes.
to promote healthy lifestyle. Thank you very much for your important comment. And are there any question or comment from the speakers?
I have a comment, Dr. Hasegawa. This is very interesting. Thank you very much for your lectures, Professor Cario. I just want to know about the digital therapy program. It's mean that you give, for example, like exercise, you give exercise to the patients. It means that you give exercise prescription every day to the patients. Is that, I mean that it is an interactive digital program or what? Thank you very much.
Interactive. So virtual nurse, the correct their personal characteristics, and then the interactively, the nurse asked what is three initiative to do right. So
it's meant that it's very individualized between one patient to another patient. Is very different.
Yes, it's important. It's important.
Okay, thank you very much.
Dr. Kashim, do you have Dr. Hashim?
Yes.
Yes. Do you have any comment or no? Okay. Thank you very much for your excellent lecture, Professor Cario. I'd like to move to the last speaker, Dr. Kashif Ali Hashimi from Pakistan. He is the Associate Professor Cardiology at Sheikh Multan, Joint Secretary, Pakistan Society of Interventional Cardiology, Coordinator, Pakistan Cardiac Society, Multan Chapter, Secretary, Pakistan Hypertension League, Multan Chapter, Multan, Pakistan. He's going to speak fixed dose combination polypill therapy for primary and secondary prevention of cardiovascular disease and death from HOPE-3 polyelan to TIP-3. Dr. Hashim, please.
Bismillahirrahmanirrahim. Thank you, Dr. Hasegawa, for introducing me. Also thankful to Taiwan Heart Federation for inviting me for this talk in this prestigious forum. My talk today is fixed dose combination polypill therapy for primary and secondary prevention of cardiovascular disease and cardiovascular death. This is just a view of my city, Multan. And this is my hospital where I am working, the CP Institute of Cardiology, Multan. This is my institute last year data of 2020. 1,97,530 patient visit to emergency department, and around 230,000 visits to outpatient and specialized clinic. 13,000 angiographies and 8,000 angioplasties and 48,000 echocardiographies being performed last year. This is just to show the magnitude of problem and magnitude of disease we are facing over here in our region. The four most important factor in our country especially is the poor patient compliance. This is important because this is important in failure of any strategy, either for prevention or treatment of any disease, including the cardiovascular diseases. This is a single pill combination. That means two or more than two drugs to address single risk factors like combination of valsartan, amlodipine, and hydrochlorothiazide to address hypertension. A polypill, a pill with multiple components targeting at least two or more than two risk factors. Example, ACE inhibitors, diuretics, statins, aspirin to address hypertension and cholesterol at the same time. This is a typical of polypill which we are talking about. Constitutes of aspirin, enalapril, valsartan, hydrochlorothiazide, atorvastatin. The polypill concept. Using a single pill may improve adherence to the therapy. It eliminates need for dose adjustment and frequent follow-up. For hypertension control, combination of low-dose medication may improve safety and the efficacy. It permits control of more than one risk factors with lower cost and pill burden. The evaluation is right from 2001 to 2002. When 2002, Salim Yusuf he proposed that 75% of cardiovascular reduction is possible by giving aspirin, beta blockers, lipid lowering by statins, ACE inhibitors, and combined effect is 75% reduction in cardiovascular risk. And this is Professor Sir Nicholas Wald, BMJ 2003. He suggests that strategy to reduce cardiovascular disease by more than 80%. And how? Treat all patients with cardiovascular disease plus everyone above the age of 55. No need to measure risk factors treatment because intervention is effective, whatever the initial level. A multi-component polypill will reduce cardiovascular mortality and morbidity and be cost effective. Statins, 3 classes of antihypertensive drugs at half doses, folic acid and aspirin. This is what he recommends. So cardiovascular disease is a global epidemic, and that's its risk factors are widely prevalent. Reducing the burden of cardiovascular disease required strategies that are applied to entire or large segment of the population. Heart disease and strokes are major causes of death and disability worldwide and are largely preventable. And the cholesterol and blood pressure are the major cardiovascular risk factors. This is important with hypertension. It does not come alone. It comes with the package. The package may include heart failure, a coronary artery disease, a myocardial infarction, LVH, aortic aneurysms, peripheral vascular diseases, retinopathy, hypertensive encephalopathy, chronic kidney disease, cerebral hemorrhage, and stroke. And studies have shown that certain drugs can effectively and safely lower cholesterol and blood pressure and prevent heart attacks and strokes. Such studies have been conducted primarily in the people who had already sustained a heart attack or a stroke, or in a people with high cholesterol and blood pressure levels. And most heart attacks and strokes occur in people with average normal cholesterol and blood pressure. Therefore, in the HOPE-3 trial, the investigators will evaluate whether a cholesterol-lowering drug, rosuvastatin, and a combination of blood pressure-lowering pills, that is, candesartan and thiazide, used alone or together, can reduce the risk of heart attack, stroke, and their sequelae in people without known heart disease at average risk. So, the HOPE-3 trials, heart outcome prevention evaluation, interventional randomized clinical trials, more than 12,000 participants, and purpose is the prevention. And the study rationale is guided increase in cardiovascular disease risk for systolic blood pressure more than 115 millimeter mercury, for LDL throughout the documented range in population. BP lowering trials indicates reduction in cardiovascular disease in high risk people and those with systolic blood pressure more than 150-160. And statin lowers cardiovascular disease in secondary prevention and in primary prevention, mainly in whites with increased LDL or CRP, diabetes, or hypertension. So study objective was to evaluate in an intermediate risk population without cardiovascular disease, the effect on cardiovascular event by BP lowering with combined candesartan and hydrochlorothiazide, cholesterol lowering with rosuvastatin, and combined BP and cholesterol lowering. So this is the intermediate population. Those included women more than 60 years, men 55 years or more, with one additional risk factors. So it includes 21 countries and 220 centers. So BP lowering arm conclusion, fixed dose combination with candesartan 16 mg plus diuretics reduced BP by 6/3 mm mercury, but did not reduce cardiovascular events. Cardiovascular events were significantly reduced in highest third, systolic blood pressure more than 143.5 mm mercury, mean 154. Results were neutral in the middle third and intended towards harm in the lowest third of systolic blood pressure. Treatment increased lightheadedness, but not syncope or renal dysfunction. For cholesterol lowering arm, rosuvastatin 10 mg per day reduced LDL by 34.6 mg, cardiovascular disease by 25%, and the consistent benefits regardless of LDL cholesterol, systolic blood pressure, risk factors, CRP, ethnicity, and importantly, no excess in abdomyolysis, myopathy, or diabetes. In combination, about a 30% reduction in major vascular events. The benefit of combination therapy largely seen in those in the upper third of systolic blood pressure, with 40% relative reduction in cardiovascular disease. In lower two third, the benefit is from rosuvastatin only 30% relative reduction in cardiovascular disease. So clinical implications, statin beneficial in all participants. BP lowering benefits only those with elevated blood pressure. The combination therapy in hypertensive leads to 40% risk reduction, benefits from both BP lowering and statins. In others, 30% relative reduction from statin alone, and the pragmatic strategy without limit or BP criteria, dose titration, and frequent monitoring. Okay, a polypill for primary prevention of cardiovascular disease, the interventional polycap study tips 3. So they start with the polypill hypothesis. Risk factors have a graded relationship with cardiovascular disease, as already we discussed. Statins, beta blockers, ACE inhibitors, and aspirin collectively can reduce cardiovascular disease by 75%, stated by Mr. Joseph and Lancet 2001. And Wald and Law hypothesized 80% relative reduction for MI and stroke, BMG 2003. The combination of 3 BP lowering drug at half dose to reduce BP by 18 mm mercury, 40% relative reduction in MI and stroke. A statin reduced LDL cholesterol by 1.8 millimole, 40% relative reduction in MI and stroke, and aspirin by 25% relative reduction in MI and stroke. The objective and primary outcomes to determine whether polypill reduce the composite of cardiovascular disease events. Aspirin reduces the composite of cardiovascular death, MI or stroke, compared to its placebo, and polypill plus aspirin reduces composite of cardiovascular disease event compared to double placebo. So aspirin in primary cardiovascular disease prevention, 15% reduction in cardiovascular events, potential reduction in cancer risk, benefits may be counterbalanced by bleeding, limited data in South and East Asian population, and unclear whether aspirin should be included with a polypill for a primary cardiovascular disease prevention. So the outcomes, aspirin versus placebo, a primary outcomes, cardiovascular death, MI, stroke, secondary cardiovascular death, MI, stroke, cancer, first and recurrent events. Conclusions. In an intermediate risk population without cardiovascular disease over 4.6 years, polypill reduced 25% in cardiovascular disease, aspirin 14% reduction in cardiovascular disease, death, MI or stroke. Polypill plus aspirin 31% reduction in cardiovascular disease. Benefits are larger, about 40% with polypill plus aspirin in those without discontinuation for non-medical reasons. And aspirin contributes importantly to the benefits. So the implications are 30 to 40% of cardiovascular disease risk reduction with polypill plus aspirin. Though it's lower than the original hypothesis benefit, but nevertheless it is important. If half of the eligible people use a polypill with aspirin, 3 to 5 million cardiovascular disease events avoided each year globally. Likely a cost-effective strategy to meet global targets of reducing cardiovascular disease by 30% by 2030. And future polypill will reduce LDL cholesterol and BP to greater extent might lead to a larger benefits. So this is the Poly-Iran study, a partially blinded pragmatic cluster randomized trial of adult age 40 to 75 years, villages as a unit of randomization, included both primary and secondary prevention. 10% had pure cardiovascular disease, mean age 60 years. and randomized either to health education and usual care or health education plus polypill, including aspirin, atorvastatin, nenarpil/valsartan, and diuretic. An outcome will be composite hospitalization for ACS, fatal MI, sudden death, heart failure, fatal and non-fatal stroke, revascularization, intervention delivered by non-physician team. So to summarize the recent data, the new meta-analysis, which was presented during a late-breaking science session at the ESC Congress 2021 and published simultaneously in Lancet based on 3 large randomized trials, that is TIPS 3, HOPE 3, and Poly-Iran, there was 38% lower relative risk of cardiovascular death, MI, stroke, arterial revascularization over 5 years of follow-up when compared to placebo or usual care. Data is population more than 18,000, mean age 63 years with no gender bias, 50% males and females, 10% risk 17.7%, and median follow-up 5 years. The results: primary outcome fixed dose 3%, control group 4.9%. Individual outcomes also benefited in myocardial infarction, revascularization, stroke, and cardiovascular deaths. Aspirin versus without aspirin. A significant reduction in primary outcomes and its components were observed in the analysis of the fixed dose combination strategies with and without aspirin, with greater reduction for strategies including aspirin. The GI bleeding was uncommon, but slightly more frequent in the fixed dose combination strategy with aspirin group versus control. That is 0.4% versus 0.2%. The frequency of hemorrhagic stroke, again 0.2% versus 0.3%, and fatal bleeding 0.1%, less than 0.1%. The treatment effects were similar at different lipid and blood pressure levels and in presence or absence of diabetes, smoking, or the obesity. So, to summarize, cardiovascular disease are on the rise in the developing countries. Prevention of cardiovascular disease and cardiovascular death is key. Risk factors have a graded relationship with cardiovascular disease risk. Polypill reduce the composite of cardiovascular disease events, and adherence to treatment likely to increase because of a single pill. But there are certain drawbacks as well. No opportunity to amend individual components, such as avoiding of beta blockers in person with asthma or ACE inhibitors to cuff and titration dose if needed. Aspirin used for primary prevention, while aspirin is indicated for secondary prevention of atherosclerotic cardiovascular disease. The use of aspirin for primary prevention of ASCVD is generally indicated when the absolute risk of cardiovascular disease outweighed the risk of severe bleeding. Controversial aspects of the polypill was that it was intended to be used at a population level without screening of blood cholesterol or blood pressure because an age threshold of 55 years and above will be used to determine eligibility for the treatment. So the final comments will be a fixed dose combination treatment strategies substantially reduce cardiovascular disease, myocardial infarction, and stroke, revascularization, and cardiovascular deaths in primary cardiovascular disease prevention. These benefits are consistent irrespective of the cardiometabolic risk factors. So when you are prescribing a single pill combination or a polypill combination, you have to address the self-care maintenance as well. As already discussed, the salt intake, you have to address regular exercise, regular walk, eyes on your weight, and no illicit drug abuse. Thank you for your patience listening.
Thank you very much for your extended lecture on polypill, Dr. Hashimi. And yeah, polypill is very important in when consider the cost benefit effectiveness. So it may be very important for the cardiovascular health all over the world. Is there any comment from the speakers?
May I have a comment?
Yes,
Professor Hasegawa. Thank you very much. Assalamualaikum, Professor Hasim. Thank you very much for your lectures. I enjoy it. But actually, that couple of months ago, years ago, we tried to use a polypill. Indonesia is part of the polypill study here, but we have a problems in the patients with the moderate because we use inter-heart risk score, and then we try to looking for and find patient with a moderate risk, of course, for the cardiovascular disease, and then we give a polypill. The problem at the time is that about the blood pressure, Dr. Kasif, because after we give a polypill, some of the patients has very low blood pressure. under 19 or 16. And then we tried to change the medications in the beginning that we should exclude the patients because of that problem. And then at that time we recruit the patients, which is a little bit prone to hypertension for the polypill. How about your comment? I mean, the hypertension effect in polypill.
This is basically the problem with polypill. You cannot reduce or increase the individual drug component, and this is the drawback, which I mentioned in the presentation as well. So in Hoop 3 as well, you have seen the major benefit from polypill are those from high blood pressure, from blood pressure lowering medications, and it's tend to be harm in lower third. While for cholesterol lowering, we get benefit in all range of the patients.
Okay, thank you very much.
Thank you very much. Yes, even though the LDL cholesterol is lower than 50 milligram per deciliter, will have no harmful effect. So in case of statin, it's okay, but in case of anti-hypertensive drug, we need to be careful. But just my comment is that are there any difference between Caucasian and European or American and Asians? Because the Asians have more tend to be hypertensive and will have more bleeding, and the Caucasian will have more thrombotic and more in coronary artery disease. So maybe the ratio of antihypertensive drugs and statin should be different for optimization between Asians and Caucasians. Do you have any comment on that?
Definitely, there is a different behavior with polypills in different areas. In my country, we don't have widely available polypill over here, but we do available a combination pill, single pill combination for blood pressure treatment, like 3 antihypertensive drugs. These are easily available in Pakistan, but polypill is not available widely in Pakistan. In Pakistan, we have little experience about a polypill use, but definitely if we look in our region, the salt intake is higher and BP tends to be higher in our population.
Thank you very much. Is there any comment from other speakers? Okay. Thank you very much for excellent lecture. Polyps are very important for all the medicine because there are so many middle and low income countries in the world. We need more study to make it common. Thank you very much for excellent lecture. And thank you very much for all of the speakers and attendants for active discussion. And we greatly appreciate tremendous effort by Taiwan Heart Foundation and especially Professor Junie Lin. Do you have any comment from Professor Lin?
Oh, this is excellent, a kind of excellent symposium on hypertension therapy. We are talking a lot about the new clinical trials, what they've shown us, and I'm particularly interested in the digital therapeutics. In this kind of age, it's really not easy to implement the kind of APP guided. So now, on the other hand, the substitution or the polypill concept, actually, they are much more easier to implement in general population. But this is going to be quite a difficult task for in Asian Pacific area. I think it's Japan, Taiwan, and also Southeast Asia and even West Asia. We all share in the same loading of the hypertension problem. So it's a very interesting symposium. And thank you for Professor Hasegawa and also Professor Chen chairing for this whole section. Thank you.
Thank you very much. Hypertension is the most common cause of cardiovascular disease and death in the world. Thank you very much for your excellent lecture, and Professor Lin, thank you very much for organization. So thank you very much. See you. Bye-bye.
See you.
Thank
See
you.
you. Bye bye.
Bye-bye.
Thank you. Bye-bye.